I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel. Welcome to another episode of Faisel and Friends. We're here because we believe that everyone needs access to treat unexpected bleed. Tonight's moderator is our Dr. Dan McCarter. Dr. Dan, are you ready to go?
Absolutely, Faisel. Looking forward to taking everyone's questions and hearing this great discussion this evening.
Excellent. And my co-host, Robert, how are you doing?
I'm doing well, Faisel. I know you're having a few technical difficulties tonight, so hopefully it's smooth sailing from here, but if something goes wrong, I'm happy to jump in as needed.
It will not be the first time, and definitely it will not be the last. I tell you what, I mean, some of the technical difficulties that we have to face still in 2021, it's like, I cannot wait to get to a place where we don't have to, maybe you know what it is, all I got to do is reboot this computer, but that's not going to happen. We're going to move forward. And to our audience, we're going to try our best to answer the questions in the chat towards the end of the show. Okay? I am very thrilled about our friend joining us tonight. I was introduced to Dr. Jack Cochran by Dr. Paul Grundy. And since our quick introduction, we've become quick, fast friends. An introduction about Dr. Cochran. Dr. Cochran is an innovative leader for healthcare transformation. In his 2018 book, Healer, Leader, Partner, he provides practical, proven knowledge and skills for physicians to become effective, compassionate leaders for improving and transforming healthcare to deliver on what patients want, need, and deserve. Under his leadership as the Executive Director, CEO of the Permanente Federation, Kaiser Permanente was recognized as a national leader in clinical quality by multiple institutions, including the Medicare STAR program and the National Committee for Quality Assurance, NCQA. The Federation represents the national interest of the regional Permanente medical groups, which employ 20,000 plus physicians who care for more than, not 10 million, 12 million Kaiser Permanente members. Welcome, Dr. Jack Cochran.
Thank you. Good to be here.
You know, Dr. Cochran, I would like to take you back to the 1990s, especially for my kids. For my kids are 13, 7, and 3. The 1990s was a time before playlists and Netflix. We had things called mixtapes. I know, it's hard to imagine. Dr. Cochran. 1990. Literally.
So Faisel's having some technical difficulties. So Dr. Cochran, I will complete Faisel's thought. So you were involved in the kind of the throes of beginning of managed care. You were leading a large organization. You know, what would you have done differently if you could do things over again with today's resources in healthcare?
Well, gosh, that's a pretty long list. I think probably to simplify it, I would have had more conviction over some of the things I saw and thought should change and wanted to change, but I had a level of inexperience that didn't necessarily translate into the boldness and the conviction that I needed. You know, just briefly, I was a pediatric plastic surgeon, and to do that, I had 4 years of medical school, 6 years of surgery residency. Before I went to Kaiser, I had 8 years of private practice. and I had been certified, qualified, examined. I had all that sort of context for competence. Then I went to KKP. I went on their board, and then 2 years later, I was elected the president of the region. And that's the leadership of the clinical and the business side of healthcare for, at that time, 700, 800 doctors in a region the size of Colorado, 400,000 patients. But for that job, my training was on the job, just in time, trial and error. And so that's what I mean by conviction. I learned on the job about leadership and business, and probably in some weird way, my inexperience had some advantage because I was aware that I was inexperienced, and I spent a lot of time listening to physicians and listening to primary care that from my specialty care practice world, I would have never understood. So I think I learned a lot of things that I tried to put into practice, and I eventually did. But I think if I had a little more conviction earlier on, I might have moved a little more quickly.
Right. So you went from being a plastic surgeon, highly trained at your craft, very precise, to having to run an organization. And very different set of skills. In plastic surgery, you are it's you and the patient in a lot of circumstances. You have a lot of control over the situation, but now you're managing people, you're managing organizations, and you're managing a whole bunch of them. What did you have to you touched on it a little bit, but what did you have to do to sort of change your mindset, and sort of what were some situations you got into that you never thought that you would have to be prepared to deal with?
Another long list. Well, first of all, the job of being the president of the regional physician group is a job that is a selected job by the physicians and their board of directors. So I went through a review and selection process by my peers. And I will tell you what they said about me that they found reasonably positive. That I was very balanced, that I was sort of a very focused doctor. In other words, they called me at 3 a.m. with a dog bite. I didn't give them a reason that I was crabby and couldn't go in. So they respected me as a clinician. They thought I had a balanced point of view. And they also said that, he's willing to speak up. And so there was a few sort of odd traits that they found to be desirable. And then I got involved in a selection process where they asked us to think out loud, and they thought that perhaps I had some of the traits that we wanted. But as I just said earlier, I was very aware of what I didn't know, and while I was scared, and that didn't make me feel bold. I hit the road. And I did a listening tour, and I met with every physician in the group, in groups of 5 or less, for 6 weeks. Every hour I met with a different group, and I took notes just to say, what is going on? What is the issue in primary care? What is the issue in referrals, et cetera? So, it was a little mini tutorial on reality, and I'm really glad I did it. I recommended that behavior to anybody taking a new job. You've got all your assumptions and all your knowledge. Go test them. Go test them with the people that really count.
Excellent. Dr. Dan, welcome to the chat.
Yeah, I'm going to join in while Faisel's working on his computer. So I read part of your book, and you obviously had to have a fair amount of confidence to make this change into leadership. And in your book, you describe a scenario with the difference between arrogance and confidence. So doctors are often considered to be arrogant. Talk about that a little bit, about the importance of confidence without arrogance.
Yeah. Actually, I wrote a little piece about that after doing a 16-hour operation with 8 surgeons one day, and I was watching these 2 lead surgeons. I wasn't one of the leads. And one was just like a peacock, walking all around, talking about all this stuff and sort of bragging about this and that. And the other one was just quietly getting the job done. I was just watching these 2, and I thought it kind of framed that for me. I think that confidence is a quiet trait. Confidence is a sense that I'm grounded in reality. I see what I see, and I'm pretty sure it's true. And I think that on balance, I either have some thoughts, some skills, or some ideas that can contribute to the solution, or I've got some friends and colleagues and teammates that can help me with that. And so I think confidence is a fairly quiet trait, and it doesn't need to be acknowledged or be in the center of attention, whereas arrogance really demands attention and demands that I'm noticed and I'm here and there. You got to think of me as being special. So I think that's the difference. And I didn't know. I also learned something else about myself, which is at the risk of bragging, that I didn't know. I didn't know I was a good listener, and that was on the job panic. I had to figure out what was going on, and I just didn't have a way. I wasn't clairvoyant. So I became a good listener, and that was a trait that I didn't necessarily have, but I developed, and I found it to be very helpful. And the other was I was courageous. And I didn't know if I was courageous. I never thought about myself in that trait. And the reason I know that is that you do have to make some hard decisions. And you do have to make some hard decisions that affect people and hard decisions that are unpopular. And I had that sort of quiet sense of, I've got the job, I've got the responsibility. I better at least go into it with, full bore. I'm going to do the best I can, even if I make a few mistakes. And so I was actually fairly courageous. I didn't know that about myself, but it taught me a lot, and I learned a lot. We can talk about it some other time with another question about the power of personal forgiveness.
So, Dr. Cochran, Faisel's sending me questions since he can't be here at the moment. So let me ask you this. So you've worked extensively with national health policy development, integrated care, innovation, and physician leadership in a very large, influential organization. And, at the time you were there, Kaiser attained national status for clinical quality recognized by a number of organizations, but it also completed the largest civilian deployment of a clinical information system. And as a health tech person, the EMR and clinical information system world is fraught with issues and challenges. And what was it like making the transition from paper charts? And how do you feel about medical records and the status of the electronic health record today?
Yeah, good, great question. Probably worth a 2-hour answer, right?
Yeah.
First of all, Kaiser did do a lot of good things and got better. It didn't start out perfect, but got better, developed sort of a learning organization. And I say that because ChenMed is exactly the same kind of organization. What you have is a culture that recognizes you will have a clear destination. You will have a mission. It was very eloquently spoken, in the intro. And I thought that was very clear. Healthcare is a right, and people have the right to get good primary care and good access. So we start with that. We believed that. And then we developed a culture that embraced measurement. And when you come from a small single doc, 2-doc private practice, most of the measurement of your success is how many chairs are occupied in your waiting room. Right? If you've got a full waiting room, you're probably doing a good job. There's no sense of what my real, revision rate, infection rate, et cetera was. So I think that we had a clear destination, what we believed in. We developed a culture that embraced measurement. And measurement's scary when you start out because you're going to find out things you don't want to find out, which is you're not as good as you thought you were. But the beauty of it is, and what you have at ChenMed and other systems of care, is you have the ability to surround practitioners with a supporting environment that says, you're having a problem with revisions on your total knee surgeries. Your revision rate's too high. Let's look at what you do and what others do. And so that culture of learning, and so embracing measurement, and then the transparency of comparison and learning, that is not overnight. That is not something you just plug in. You've had to develop it at ChenMed over years, and so did Kaiser. So when people say Kaiser's great, Kaiser's very, very good, but it was not as good 20 years ago, and it was not as good 10 years ago because of embracing that notion of we know where we're going to go, we're going to measure, some of the things we're learning, and then we're going to share it with each other. And that's very challenging. Physicians, like a lot of professions, are very highly skilled and very accustomed to being notable and bright and accomplished and all that. And it's not natural or easy to necessarily, okay, bring me on the 10 things I'm doing poorly or doing below average or doing that sort of thing. We've all been on that curve of, we got to make A's in chemistry. And so this lifelong learning is really enhanced by being in a system like a medical group or a system of care. It's very hard to do that in solo individual practices.
Mm-hmm.
Now, so the question about the automatic health record, I went through two big implementations. One is when I was still in private practice, still in practice at Kaiser, we went from no record to a home-designed IBM record, which was very basic and had lots of limitations. But after we got all of our physicians on it, and by the way, it was like pulling teeth. And I wasn't in leadership then. I was probably one of the cynics out there. But even physicians, and I will reference, senior doctors like myself, who weren't necessarily computer literate or computer facile, and were actually a little bit embarrassed to go through the implementation because they exposed that limitation. I did. Even that group, if you said, okay, it's a year later, we'll take the computer away if you don't like it, they would lay in front of their door and say, no, you can't have it. And that was because they really learned that the ready, available access to data and information and prior notes was so much better than the computer that they had used before. And, I talk about the office visit 1.0, which is doctor, nurse, and patient, and this was the computer, and the record was a paper chart, which is very risky. And then once we got into the implementation of the IT system, we had new problems, but we also had new opportunities and new solutions. And our physicians really enjoyed that. They never thought the system was that good because it wasn't that good a system. And then the second implementation, I was still in the region at the time. We went from our IBM system to Epic Systems, which we call Health Connect in terms of Kaiser. And we already had a up and running culture of computer literate physicians. We went from IBM to Epic, 700 physicians, 17 clinics, 400,000 patients in 4 weeks.
Wow.
4 weeks. That's a change management story that is worth listening to sometime, but it wasn't random. Lots of prep, and it wasn't me being charming. It was lots of preparation, being very intentional, and being very specific in how we did the change management.
Right. The EMR implementations at any organization is a big lesson in change management, and the folks that do those implementations are masters at change management and project management and handling a whole bunch of contingencies at the same time. So
yeah,
I can appreciate the
level of effort I love
big scale.
Again, sort of going back a little bit to the notion of culture. Wouldn't it be great if what Faisel said was universal and people around the world were saying, I believe that healthcare is a right, and we want to, as an industry, as a profession, raise all boats and build this great opportunity for our patients, because after all, isn't that our real stakeholder here? And so we need to become more of a learning industry where I can learn from ChenMed and you can learn from Emory, and we just don't do that as openly or as well as we could. And so in a world where we have good data, we have good patient identification, we have good coding that has some rationale to it, and then we have interoperability and the agreements to share data. The upside is exciting, but we just aren't there. We're on that journey.
Right. Absolutely.
Dr. Cochran, I'm back. Hopefully I'll be here to stay.
Good.
Hopefully you can hear me. I love what you said about the change that you made and the way that you made that change happen so quickly in 4 weeks. In my residency training, we had a hybrid. We transitioned from paper charts to electronic records during my residency training in the hospital, but it was a hybrid. Our charting was done on paper, and all the imaging and everything was scanned into the computer so we could search through previous notes. Still quite cumbersome, but it was a difficult transition. It was very
hard for the physicians to go from writing their notes quickly, putting in just the date, you put in a quick note, you put in some orders, and it was clean and it worked, to having to go through the computer. It was just that learning curve, and this is just within the last 15 years, was a big learning curve.
Yeah. Well, and that was before. Today, we now understand, and again, the learning curve is all over the map for physicians, the power of aggregated, identified data that can be analyzed and put through algorithmic, scrutiny, and then come up with projections. And I mean, the use of AI and using data in a much different way is so exciting. And I think it will start to, if we continue to learn smartly, start to deal with this dilemma we have, which is a healthcare system that has miracles and breakthroughs and cures, and yet high levels of quality issues and significant affordability issues. And that's on the patient side. And then on the doctor side, miraculous opportunities to deliver great care and do the greatest care imaginable, and doctors being unhappy and miserable. And the facts are, those two problems cannot be solved in series. We don't say, okay, we're going to solve the doctor problem for the next 5 years, and then we're going to work on that as a patient thing. Because we got to start thinking that the systems of care that we design have to serve all of those things. And who is more central to that than the patient? And who has the most disproportionate impact on the patient but the physician? So I don't talk about physician leadership as we're more important than patients or nurses or anybody. No. But we have disproportionate impact. And we have that impact. We've earned it, and we need to keep it because of trust. We have that trusting relationship that says to a patient, I trust your information, I trust you're going to be there for me, etc. I can help you manage through it because we have this great relationship. Same with nurses, same with people around the hospital system. Physicians should be in the center of all those discussions. You referenced my book, Healer, Leader, Partner. Well, the non-book before that were two physician traits that I saw regularly that I thought were completely disturbing and dysfunctional. One is physician as victim. Physician as victim sighs, whines, and references all the external things that are wrong, that are the reason that things aren't good. And even though many of those things are truly wrong, once you take the role of victim, you have become helpless. And patients don't need helpless doctors. So that's physician as victim. The second role that doesn't work, although it can get the job done, is physician as tyrant. And physician as tyrant says, I'm in charge, I got the big degree, we're doing it my way, let's go. If you've just cut across the aorta, that's probably okay. But that's a very unhelpful role. So I came to Healer, Leader, Partner because I realized as healthcare became more complex, I was trained in the healer. How do you do good care, good surgery, make sure you're doing things well, develop the trust, develop the skills. And then all these other things were going on in the world about affordability and access and all these other things. And nurses are unhappy. And so I said, is it legitimate for me to not hide inside the healer role, but to take the healer role as that's my watch, that's all I'm into, when these other things are going? Patients encounter the healthcare system physically, socially, psychologically, financially. We can't lean in and lean out. And so the role of leader says, I have to have some accountability around affordability. I have to have some responsibility. Because our patients, whether they have good insurance or no insurance or whatever, are rationing healthcare at the kitchen table.
Yep.
They are sitting there and saying, we got a $5,000 deductible this year. And Johnny needs his tonsils out, but the clutch just went out in my truck. This month, we got to get the truck fixed because I got to get to work. Patients are rationing healthcare at the kitchen table. And we can say, it's the hospitals, insurance companies, it's the pharmaceutical. That's physician as victim. Physician as leader says, I better lean in. I don't have to become as smart as the finance guys or the operations or the IT guy. I better have my good clinician hat and my learning hat to say, how can I participate in that conversation? And then physician as partner wakes up to the fact that this is truly a team sport. And the idea of healthcare team 1.0, which is doctor, nurse, and patient, and I'm the one, and I'm the guy, and I got the computer, too much complexity. Knowledge has exploded, technology has exploded, all these things have exploded, and every specialty has gotten more knowledge and more complexity. You can't just say, it's all got to go through me. You got to learn how to work differently and better with nurses and pharmacists and subspecialists, et cetera. But I'll close by saying the final thought that I've developed in the last 5 years that is really a little bit out there is because people, I go back to physician as victim, and they go, well, things would be okay here in Tampa if it wasn't for those suits.
Yeah.
And those are the finance guys on the second floor, or those geeks. Those are the IT guys on the third floor. Guess what? Those two specialties are on the healthcare team. They are on the healthcare team. They work in healthcare. They work for healthcare organizations. They're trying to solve healthcare problems. And if our attitude is you're bad and you're over there, or you're just over there, whether you're good or bad, and I'm over here doing the Lord's work, right?
Yeah, that's right.
You've got to understand the role of partner. And the role of partner is not to be the tyrant, but to say, yeah, I am humble. I don't know what's going on, but let me tell you something. When you said that about how you thought a computer system ought to work, I need to give you a little bit of my point of view, because I think you may design a perfect computer system that's going to make doctors and patients crazy. And they're not trying to do something sinister. They're just trying to do their jobs. So a physician as partner is not leader, but says, I'm going to be available. And don't say, those finance guys, affordability is their responsibility. No, let's go back to trust. 83 cents of every healthcare dollar is spent on healthcare delivery. And the core of that is the trusting conversation between doctors and patients. That's where that 83 cents gets spent.
It's almost like as the transition happened, we switched to electronic medical records, and then suddenly also the doctors had to justify billing codes, level 3, level 4, level 5. So now you had doctors who had to learn this new medium. They had to start putting fluff in the chart to justify different levels of billing, and the targets of our frustration were the IT folks and the finance folks, when it wasn't either their faults. The IT folks were just trying to build something that would help us do what we needed to do, and the finance folks were just working within the fee-for-service system.
Yeah.
I wonder what would have happened had we not had that fee-for-service model. If we had more of a value-based model, a model where the doctors are more focused on the assessment and plans, more simplified documentation, I wonder if that transition would have been better. But I guess now it's neither here nor there.
Well, a lot of our colleagues that we trained with, whether it was in school or in residency, they weren't bad people. They weren't immoral. They weren't evil people. But you drop them into a fee-for-service system, and they're not only clinicians, they're also breadwinners and fathers and husbands, and they've got to figure out how to run the business too. And there's a lot of gray areas in the fee-for-service model, and it's a very tough model to exert all the things that you should as a value-based clinician, et cetera. And so, yeah, I think it's a very flawed model. I think that some level of prepayment and value-based is where we need to go. It seems to be very hard to do and very slow. But right now, the amount of wealth transfer in our country, not only with families rationing at the kitchen table, but employers deciding between raises in their salaries versus healthcare benefits, governments deciding how to ration healthcare. It's not yesterday's or today's problem. It's all around us, and I think that I was very disappointed that Warren Buffett, Jeff Bezos, and Jeremy Diamond didn't see further the Atul Gawande. I thought they were going to really lean into something, but it's tough. It's tough because the reason healthcare is tough, this is a little bit theoretical, but there are simple problems, complicated problems, and complex problems, right? Simple problems, you've got a sore throat, you have a strep positive, you get a prescription, it can be done algorithmically. A complicated problem might be doing an operation. You get the right diagnosis, the right team, the right venue. And then there's a complex problem, which is creating a healthcare system. And the problem with that is it doesn't lend itself to somebody being in charge and a linear progression of things, because you can do a great job of solving healthcare's needs, and if you've left out the pharmaceutical industry, you're not going to get where you need to go, or if you've left out the doctors, or if you've left out. And so the reason that complex problems are tough is because it takes the patience to collaborate and to listen and to take people with disparate views and have the courage to roll up your sleeves and say, we're not leaving until we find ways that we can get the best solution, because we'll never get our solution or a perfect solution.
Excellent. Yeah, Dr. Cochran, one of the points I think you made that is very important is that in the United States, we don't even have full healthcare coverage. There's still, at any given time, 8 to 10% of the population, at least over the past 15 years, that has not had access to or healthcare coverage. So, that's where you do get a lot of people who are making rationing healthcare decisions at the kitchen table. And, we in the United States haven't even solved that basic problem. And that alone is something it says something about the amount of effort from a high level that's being put into really rethinking and caring about the U.S. healthcare system.
You can imagine what it did to me, the number of times, because I've spent a lot of time with in the international world talking to health ministers, etc. I've sort of been around because of the Kaiser job. You can imagine how it was very, very embarrassing for me to answer the question. So why don't Americans think healthcares are right? Why don't you think healthcares are right? Aren't you the richest country in the world? We think healthcares are right. Why don't you think healthcares are right? So that's a very interesting issue, isn't it? And yet everybody says, well, the British system is flawed and the Canadian system is flawed. Yeah, they all have their strengths and weaknesses. There's not a perfect system. But again, physicians who embrace being healers, leaders, and partners can take this seriously and start to be in a different leadership role. Have different relationships with the finance people and the IT people. Have different relationships. I know it's idealistic, but if I was not an idealist, I wouldn't have the energy to continue to push some of that stuff, because my grandson needs a good healthcare system. Okay,
right.
I mean that's
right.
That's important to me.
I can't understand. There's like a American like there is this feeling that they don't want socialized healthcare. They don't want single payer healthcare. But when you go into the current system, our people don't seem to ask themselves this is horrible. This is really bad. Could something be better than this? And it's always shocking to me that there's a lot of people who are like, I would much rather have what we have now. And yeah. I find that rather interesting, because it's not good.
Without beating it to death, if you spend much time in Great Britain, you will understand that the National Health Service is a source of tremendous pride to the British people. Free at the point of care, universally available to everyone. I mean, they're very proud of that. And then you say, how's that working as a patient? And they go, it's bonkers. We got big queues, we got this and that. So, I mean, it's very interesting. But yeah, the American sense of independence and all that. I think the reason I like the fact that Warren Buffett got interested in healthcare is that even if you only cared about the economy, you should care about healthcare. Exactly. Even if you didn't care about the ethics of access and all that, if you only just care about the economy, because the wealth transfer is non-trivial at the family level, at the community level, at the government level, at the corporate level, at the national level. And could we use another 8% GDP on something else? Probably could.
Yeah, I mean, just the fact that wages really haven't gone up on par with inflation is largely attributable to increased healthcare inflation, when employers and organizations have to devote more to that spend, as you brought up earlier, and that is a big problem. And besides the fact that effective healthcare systems produce healthier, happier people who are more productive and therefore more economically productive, that's beneficial. On top of the fact that wage growth has been stagnant because of healthcare costs as well, it's not good.
Well,
It's not good for society.
the other thing is that those other countries have a very strong primary care-based healthcare system too, and that's we have gotten very subspecialized, and then we've chosen to pay at different levels based on subspecialty. So we've done a lot of things that were sort of entrepreneurial and that sort of thing. I will tell you, just parenthetically, I had an experience in about 08 to 10 or 11 where I was the senior executive from Kaiser Permanente. I worked with Jenny Cortese, who was the CEO of Mayo, and a guy named Greg Paulson, who was the COO of Intermountain, and our 3 teams. And we worked with 5 Democratic senators and 5 Republican senators, led by Ron Wyden, Democrat from Oregon, and Bob Bennett, a Republican from Utah. And they worked together, and they talked to each other, and they listened. Lindsey Graham was one of them. And we developed something called the Healthy Americans Act, which is a sort of a competitor with Obamacare. And they worked together. That was less than a decade ago. I mean, the place has really gotten crazy in the last recent years. They can work together. And it wasn't just that Wyden and Bennett were masterful, but we rolled up our sleeves. We got down to real problems, real issues, and just us chickens behind closed doors. It was a little hard to just go to CNN or Fox News and blame all the other people. It was 5 and 5, and they worked together, and we developed a bill. It didn't get to the floor, but it was the Healthy Americans Act.
Dr. Cochran, I would love to talk with you about that in particular. Not tonight, but at a future episode. I'd love to hear your insights with how, especially now with how polarized the country has become. I'd love to kind of tap into your brain to see that how were you able to make that happen? But before before tonight ends, I have some questions.
They were polarized. Let me just finish that sentence. They were polarized ideologically in some ways, but they had a certain respect and a certain grace in dealing with each other. So Bennett and because Bennett was very conservative and Wyden was very liberal, they would actually at times we had these weekend sessions, they would start laughing at each other. They go, "Yeah, I know what you're going to say here, Bob. I know where we're going here." They would laugh at each other's ideological difference. But the subplot to this is, as we got to the end of it, Bob Bennett was up for re-election in Utah, and he was a banker, a grandfatherly, dignified, gray-haired man, Mormon leader at his church. The Utah State Republican Caucus kicked him out.
Oh.
He did not get nominated for re-election. It was the Tea Party era, and they said it was because he was too chummy with Ron Wyden.
Wow.
I mean, we had Ron Wyden and Lindsey Graham and a guy named Nelson from Florida and some others at the same table looking at data with us. And I thought it was easy. I remember we went to Senate Finance. I got to testify at Senate Finance one day. And at the end of it, this youngish, probably middle-aged woman senator comes up to me and starts asking me questions. And I don't think I've had anybody in healthcare ask me more discerning, more specific, more targeted questions. And I said, "Who is that?" And they said, "It's Senator Klobuchar from Minnesota." She was on her edges. She knew what she was talking about. I didn't know her.
Well, Dr. Cochran, we're going to take a quick 15-second commercial break from ChenMed. And when we come back, I'd like to ask you some questions specifically around physician leadership, with steps that doctors can take to feel more empowered. I love what you said about doctors not feeling like the victim acting like the victim, doctors being more savvy. So I want to ask you one or two more questions when we come back from our commercial break, specifically around physician leadership. So before we go into the commercial, I just wanted to announce that ChenMed is growing. We currently have centers in 10 states. We are opening in Texas and Michigan this year. We'll be in 12 states. We're on track to open another 500 plus centers over the next 4 to 5 years. Incredible growth. And we need doctors, we need nurses, we need people to help us with expanding our full risk value-based care model. Our centers exist in underserved communities across the country. Earlier today, I myself was in North Tampa administering the COVID vaccine to underserved patients. It's not an issue with the underserved community of vaccine hesitancy alone. It's about access. And so please take a listen to our commercial from ChenMed, and we should be back in about 15 seconds to wrap it up with Dr. Cochran about some questions specifically regarding advice for doctors interested in pursuing physician leadership.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
I don't know when you guys are coming to DC, but I didn't see a dot on there, and I'm looking forward to it.
It's definitely not a question of if, it's just when, I promise.
Excellent.
Okay, well, Dr. Cochran, it's going to be very hard for me to call you Jack. Ask Dr. Dan. He's been saying for a couple of years now, and he's forever Dr. Dan for me and my children. It's out of respect.
I always joke with people. I say, well, that's okay, but if you meet me on an airplane, don't say hi, Jack. They'll drag you off.
Well, Jack.
That's a joke. You're supposed to laugh.
Well, you've been an advocate for physician leadership now for years. What would you say motivates physicians to keep moving forward in this healthcare delivery system that doesn't support them?
Well, I think that we have choices. Things are tough. Things are tough for patients and tough for doctors, tough for nurses, etc. And we can take the choice of victim and tyrant, or we can say, no, I can't do that. I've got to lean in. I've got to find some way. Now, that doesn't mean you say, okay, I'm going to be a CEO of something tomorrow, or I'm going to be the dean of something. It says, I'm going to embrace the sense of accountability that I am going to be a leader. It is not something that you do by declaration. It's a commitment. And you volunteer, you learn, you seek to learn. You seek people out like you or me and say, how did you do it? What does it look like? How do you learn? Because the problem with medicine, it's like engineering or everything. We are so programmed to live and die on individual competence and academic prowess that we got to be the smartest dude in the room or we're in trouble. And leadership ain't that way. Leadership is messy, and leadership is about, I care about this. I don't know exactly what's going on, but I'd like to speak up, and I'd like to hear your point of view. I would say that leadership in one sentence is something like, leadership is a process of listening to somebody else, acknowledging what they have to say, challenging their words, adding your words, and to begin to co-create understanding and co-create knowledge and co-create a bigger sense of reality so that you can then start to co-create solutions that you can test and work on together. It is not a fast process done by geniuses overpowering other geniuses. It's an iterative process of listening, acknowledging, challenging, to co-create realities. Because one of the things I say in my second book, Be the Leader Partner, is so true. I call it the crux. And the crux is, look at yourself, look in the mirror. What are your beliefs? If you believe that your fellow man / woman, your fellow colleague is sort of, they're kind of out for their own good. They're sort of selfish, and they're sort of, they're just they're in it for them. If that's how you believe, and you're going to have a communication with them, what are the tools you use? Well, you probably use manipulation, fool them, force them. They're not going to go along with it anyway. So how do I trick them or manipulate them into a point of view? If that's how you think of your fellow man, if you think of your fellow man as somebody who's, pretty reasonable and pretty open, you approach them differently. You approach them with listening, acknowledging, understanding their point of view, building on that, to start to co-create a base of knowledge. It's a little slow. It's a little slower. But I'll tell you what you find. Over time, and you got to invest in leadership training. You got to do those things, and you've got to be in a structure. Like ChenMed is perfect. It's a structure. You can take your budget and say, we're going to invest a certain amount of money in doctors being in leadership roles. And the old fee-for-service rules is, well, that's a waste of money. You're not earning anything. Well, that's a mindset and an assumption that I long ago got rid of. But you invest in people being leaders, so you invest in their training, their development. You give them time. You give them support. So you start to say, we're going to develop leaders, and we have this. I call it the coalition of courageous colleagues.
Yes.
I've been working with a group of people from Australia for about 6 years. And it's a completely random process where I met a few friends, they met a few friends, and there's about 60 of them. They're mostly GPs. And I get together with them on the phone, PRN. But it's so funny because I'll be talking to them and we'll be doing a Zoom call or something, and somebody say, well, remember what Jack said in Sydney in 2016? And I go, oh, really? That's what Jack said? But the Coalition of Courageous Colleagues says, it's not weird to do what you do. So it's not weird to be a leader. It's not weird to be part-time. It's not weird to do what I do. And help each other and learn from each other. Robbie Pearl and I worked in the same organization as leaders. We didn't always get along on things. We disagreed on certain things. But, I think that physician leadership is not the only answer. But every time we opt out, the patient loses a voice. And we've got to develop, and we've got to pay attention to careers. This notion of burnout in the physician career. I took this seriously in 1999. If you read the first book, I said, our doctors are not overworked. They're over frustrated. They're not getting the kind of support they need. They're not, the computer was wacky, and then the support and the team development, they weren't overworked. Doctors are used to working hard. And you take somebody who used to work 80 hours a week, give them a 50-hour-a-week job, and they're unhappy and burned out. Something's going on. And we've got to approach the career issue just like any other scientific issue. What's the hypothesis? What data are we going to gather? What are we going to learn? How are we going to learn from each other, from our coalition of multi-specialty groups? And then how are we going to progress and learn together? The career issues are not insoluble. They can be solved. But we've got to acknowledge it's a problem and work together on trying to solve it. And it's not just about more money or less time. We are hardworking professionals. It's an honorable craft. We need to honor it. When I made physician career my first priority in 1999, my language was preservation and enhancement of career, because our doctors were burned out, crabby, and not overworked. And I said, this is a bad situation. And so I never said protect them or give them what they want. I said preservation, enhancement of career. And my frame of reference was, this is an honorable profession. And I know every one of these men and women at some level. And I know this, they may be crabby at 45 or crabby at 55 or checked out at 70. When they were 21, they were applying to school and they had to write a paragraph in that little application. Yeah. Go back and read those paragraphs. That was a 21-year-old idealist, teeming with energy, hope, enthusiasm, brains. That person didn't die. Between the system and how they reacted to the system and everything else, the system has taken its toll. That person is not dead. And there are still people out there that are still very happy as doctors. And so probably more in ChenMed than they are down the street in their small practice. Right? Group practices tend to have, ask Robbie, group practice doctors tend to be happier.
It's true. It's true.
They got security,
Yep. I mean, we definitely do have our share of burnout as well. It's not that we're avoiding, and our share of burnout is from the PTSD from fee-for-service. Doctors feeling the need to still fill in the fluff in the chart. It's like we have to reprogram the doctors to find that balance with making the shift from the patient's chief complaint, which is like the minute clinic visit, to the doctor's primary concern of the condition that's going to end up causing them to need to see a specialist, or if it's not checked, or end up in the hospital or the emergency room.
I remember at one time, and this is antiquated data and probably doesn't apply, and I'm a surgeon, I wasn't a dermatologist, but a dermatologist friend of mine said, go look at dermatology bills. And he says, you look at 10 dermatology bills and you can tell me what the Medicare legislation says. And what it says is every dermatology bill, the doctor froze or treated or scraped 3 lesions or something like that. And the reason is Medicare pays 100% for the first lesion, 75% for the first lesion, second lesion, 50% for the third lesion, and 20% for every lesion after that. So the way you manage that is you do 3 and bring them back. You do 3 and bring them back. And, programming waste.
Yeah. Well, I guess it's part of the reason why 80% of the doctors are specialists, and we have 200,000 primary care doctors, 800,000 specialists in America. And it's all lopsided. It's all lopsided. Every aspect of it is lopsided. I love what you said about investing in leadership.
There is no study I've seen or no evidence in the world that doesn't say the best health system outcomes are when you have a strong primary care base. That has been proven over and over and over again. And this world of complexity, the first wave of complexity was, more knowledge, more information. The heart used to be taken care of by the cardiologist. Then you got an interventionalist and a muscle doctor and a valve doctor and a Purkinje fibro doctor, and you got all these subspecialists. And that was driving more subspecialty, specialization. But the second wave of complexity brings primary care right back to the center. And so I say the first wave of complexity, where we got more and more knowledge and more depth in every organ, made specialty care more primary. You got your heart problem, you went to your cardiologist, and they took care of it. But the second wave of complexity is multi-morbid patient, multi-comorbidities, which is we got your heart failure under control, but now you've got asthma, or you've got depression, or you've got your creatinine's going up. Subspecialists are not trained to manage multiple comorbidities. And so the second wave of complexity, which is what we're all about in this world, says there has to be a strong primary care team right in the center of this, so that the specialists can say, we know who's in charge of what's going on, which is the patient and their doctor. The second wave of complexity, this multiple comorbidity, and I say the first one I said, the first wave of complexity made specialty care more primary. The second wave of complexity makes primary care more special. Have to have more primary care to take care of this multiple comorbidity. Doesn't mean you've gotten smarter as a primary care doc in cardiology and nephrology. It means you're in charge with that patient of good thinking, good trust, good decisions, and holding us specialists accountable. And that's the team.
Dr. Cochran, I have to bring you back. We are approaching an hour, and I asked you to come join us for half an hour. I have many more questions for you, many more questions, especially around the primary care that's being delivered by specialists. I hear about neurologists getting headache referrals and orthopedic surgeons getting low back pains and things like that. So I would love to be able to talk with you more about the ideal structure and culture for the ideal primary care delivery system. And I have some more questions about physician leadership, but we are literally approaching an hour, and I feel terrible that we've gone this long. We didn't even get to take any questions from the audience.
So Faisal, I didn't feel bad about it until you just said that, and now I feel bad about it. I'm going to insist that you double my honorarium.
There we go. There we go. We'll definitely do. We will definitely do that. I
Listen, I go back to the belief in the coalition of courageous colleagues. I never run out of energy to help and work with and encourage and mentor people who are trying to do the right things. I never run out of gas for that ever. I ran out of knees, but I'll be back on two knees pretty soon. I'm doing actually very well. I'm walking without a cane, although I look a little bit like an old guy when I walk. But I'm doing well. I'm happy to know you, both of you and your teams. I'm happy to do this again, do more of it. It's meaningful to me. You know, when I left KP, I said it was time to move on, do something else. But I said I still got kids, grandkids, friends. This healthcare system still needs good, strong physician leadership, not tyrants, not victims. And I think I've got something to share. So
you definitely do. You definitely do. I can't wait to bring you back.
All right. Well,
Robert, what an evening with Dr. Jack Cochran. Dr. Dan, what an evening.
Absolutely. Great discussion.
And to our audience, I want to apologize for not being able to take any questions tonight. We just went over. I promise what we'll do, we'll bring Dr. Cochran back. We'll announce it. We'll give at least a couple weeks notice. Please leave your questions for us. We'll get them over to Dr. Cochran. We'll bring him back. He has a lot of knowledge, a lot of insight to share. It was such a pleasure to hear someone like him share his life experience. It was a pleasure, an absolute pleasure. Thank you so much, Dr. Cochran.
Thanks. Nice to spend the evening with you guys. Take good care.
And to all of our audience, thank you so much for joining us tonight. For more information about tonight's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.